Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasato. Dr. Biasato is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasato for Delaware Healthcare Reality.
Hi, I'm Dr. Nick Biasato. I'm here for our podcast from the Medical Society of Delaware, Delaware Healthcare Reality. This month is Suicide Prevention and Awareness Month, and our subject today will be suicide. And on the 17th of this month, it is Dr. Suicide Day, so that we can also incorporate that into this program. And we have a special guest who's a bit of an expert in this area, and that's Dr. Katie Godfrey. Dr. Godfrey is a clinical psychologist and director of the Center of Work-Life Wellbeing at Christiana Care in Delaware. Her bachelor's degree was from the University of Toronto in psychology and human biology. Her master's degree and PhD in clinical psychology with a focus on behavioral medicine, it was from San Diego State University. She has worked in a range of academic medical systems for over 10 years and previously managed care for the caregiver, Christiana Care's peer support group. Dr. Godfrey is passionate about development, implementing, and studying programs to improve well-being and has 40 high-impact publications. She has presented on the topic of professional well-being worldwide and provides consultations to help other organizations and teams who are developing wellness programs for healthcare professionals. Welcome, Dr. Godfrey.
Thanks for having me.
You're welcome. I was quite surprised to the extent of professional suicides that occur each year. And what is the prevalence of doctor suicide, and what do you make of this statistic?
Well, I can tell you a little bit about the statistics, the best that we know them, because the research is still ongoing, and it's not a perfect science to study it. So within the U.S. population overall, suicide is the 11th leading cause of death, so already pretty high prevalence within the general population. And we know that healthcare professionals are at higher risk for suicide compared even to the general population. And that prevalence of death by suicide is more common among physicians and other healthcare professionals than the general population. So there's different estimates in different studies, but some research suggests that male physicians have a suicide rate that's about 1.4 times higher than the male general population, and that female physicians have a rate about 2.2 or 2.3 times greater than the general female population. This higher in medical residents and medical students, compared to age match comparisons. And there's a similar pattern even for nurses being at higher risk for suicide compared to gender and age matched populations. So, physicians in general have a higher rate of suicide than what you might expect from similar kinds of professionals and folks in similar genders. And across their career, more than half of physicians know another physician who has either had thoughts of suicide, attempted suicide, or died by suicide. So it really touches a lot of the physician community. It's estimated that 1 million Americans lose their physician to suicide every year. And I've heard estimates that in the U.S., there's one physician who dies by suicide every day. So those are some of the staggering statistics that I think the general population isn't really as aware of.
What causes a physician to take such drastic action?
So there are lots of contributing factors and risk factors for suicide. We can't say for sure what are the causes for groups or for individuals in general. We can only kind of examine the risk factors for suicide. And there's one model in particular I think that's been really helpful to understand broadly some of the risk factors for suicide, and it has three major elements. One is failed belongingness or loss of connection. The other factor is the ability and kind of loss of fear of death, and then burdensomeness, feeling like a burden. And so for physicians in particular, if you can imagine, let's start with the ability and low fear of death. So physicians tend to know more compared to the general public about lethal means that one might use to die by suicide. Perhaps they've also seen, patients who have attempted suicide or died by suicide. So medical professionals in general tend to know more about those lethal means, and we know that exposure to death and dying through their profession can also lower their fear of death compared to the general population. So that kind of puts them at risk relative, to the general population based on that ability and low fear of death. If we think about failed belongingness or loss of connection, when we no longer feel connected to, supported by others, welcomed by others, as human beings, as social creatures, that is kind of a fundamental need that's not being met and can put us all at risk for suicide. But when we think about medical students or medical residents or even physicians, attending physicians who might be relocating geographically for training or for their jobs, it kind of uproots us from our social supports, right? Our family, our social connections, our friends, and that can put us at risk, right, as physicians. So, and the last factor, burdensomeness, when physicians feel like they're a burden to others, could be due to things at work or maybe things at home. They can feel like they're not pulling their weight, they're not contributing in ways that are effective or important, and this can actually be one of the kind of elements of burnout, right, where you're not feeling as effective in your role. That can actually be a contributing factor to risk for suicide. So that feeling of being ineffective, feeling like you're not contributing, and that sense of guilt of I'm not doing what I should be doing or contributing what I should be contributing can lead to a feeling like a burden, which we know is a risk factor for suicide.
Got it. Okay, what can individuals or organizations do to reduce the risk of suicide, and what are the best practices?
So there's a lot of stigma around getting help as a physician, and we didn't talk about that as one of the risk factors, but I think it is a major risk factor to consider that's really unique to physicians and to healthcare professionals, and so working on reducing that stigma is incredibly important. There's some really important research looking at how medical students perceive receiving mental health treatment that they personally don't consider it a sign of a personal weakness or ineffectiveness, but when it comes to worrying about how they'll be judged by other people, they're worried that they're going to be judged by their program directors, supervisors, or students, even their patients, for needing to seek out medical treatment or mental health treatment rather. And so that kind of stigma is a huge preventative factor to folks actually receiving treatment and getting the help that they need. So individuals and organizations can do a lot, I think, to improve access to mental health services, to reduce the stigma, and to kind of break the silence on the fact that this is an important issue. We talked about the fact that September 17th is Physician Suicide Awareness Day. It's a day created around reducing the stigma and breaking the silence, talking openly about it. I mean, I think the fact that we're even having this conversation is speaking to the fact that it's something that's less taboo, right? If we had been talking in the 1970s about physician suicide, people would have thought that's not a thing. It doesn't exist, right? Because it was so covered up. It was so taboo, such a stigma to talk about it. The fact that we're talking about it now, the fact that there's a day of national recognition and awareness goes a long way to reducing the stigma. We can also have, folks within our organizations or even public figures talking more openly about having received mental health treatment, having come back and recovered, having returned to their careers if they needed to take a break. There are some really important messages I think that people facing crisis need to hear, that it's okay to get help. It's not going to put your career at risk. We're doing a lot of really good work in the state of Delaware, actually, in particular, but across the U.S. to change the language on licensing and credentialing applications so that we're removing some of the really stigmatizing questions that were there around, have you ever had a diagnosis of a mental health concern, or have you ever sought treatment? And really focusing more on asking physicians and all healthcare professionals, is there any reason why you might not be able to practice safely? It could be you got in a car accident, you broke your arm, and you need rehabilitation for that, or any reason at all. But removing specifically the questions around mental health, because they had for so long, I think, planted the seed of fear for physicians that if I do seek help, if I do get treatment, I'm going to face professional repercussions. My license will be in jeopardy. My credentialing will be in jeopardy. I might lose my livelihood. That fear is real. That stigma is real for a lot of folks. And so there's a lot of work being done to change that language, to reduce that stigma, and to make it easier for folks to access support resources.
Tell me, Dr. Godfrey, what has legislation in our state in particular done to help keep the anonymity and make them comfortable with going and complaining about their problems before they get to the point of suicide? What can you tell me about those bills?
So we've had a lot of success in recent years and a lot of support to pass some really important pieces of legislation, specifically for physicians and also for all healthcare professionals. So in 2022, Senate Bill 300 was passed, and that removed kind of a mandatory reporting requirement for physicians to disclose if they became aware that a colleague or they themselves had ever sought mental health treatment. So that was a huge win, I think, for making it safe to receive even peer support, to go to a colleague and say, I'm not feeling well, I'm not feeling like myself, I think I need some help, I think I need some support. Do you have any recommendations? Is there a therapist that you know of or a psychiatrist that might be a good fit to talk to? I think having some of that mandatory reporting was silencing for physicians in Delaware, making it seem like they couldn't really speak openly if they were struggling. They couldn't trust that going to a physician colleague was safe.
And so fear of losing their license or having a sanction.
Yeah, right? and truly not knowing what happens after the report, right? I think that uncertainty of, okay, someone's mandated to report, but then what? Then what happens? And I think that fear of the unknown was a huge silencer and a huge reason why physicians in Delaware felt they couldn't safely talk to their peers about their mental health or seek support. And it's unfortunate because we know that the earlier people can reach out for help, the better. Mm-hmm. Another big one that happened this past year was Senate Joint Resolution 6. So that was passed, which gives all of the licensure boards in Delaware that license healthcare professionals a year to update their licensing language on their application and renewal forms so that we are no longer going to be asking about if physicians or nurses or any healthcare professionals have had a diagnosis of a mental health concern in the past, have received treatment in the past. It complies with the Americans with Disabilities Act, so it really only asks about if there's any reason why you are currently unable to perform your job safely. Okay. And so it's not kind of having any bias towards mental health concern or physical health concern. It's really just about, are you able to do your job competently and safely? And really should, I think, go a long way to make physicians and other healthcare professionals in Delaware feel like it's safe to go and pursue mental health treatment, to get that support. Great. Because they will no longer have to be reporting it to the licensing board, which again is they didn't always know what would happen after. Exactly.
So they feared getting help. I understand, and that you touched on the rate of physician suicide is higher among females physicians as opposed to females in other professions. Can you answer why?
Yeah, there's been a lot of research to try and understand that exact question. I think it's something we're still trying to learn more about and understand more about, but I think the best research that we have suggests that there are a couple of factors at play here. One is, we talked about failed belongingness as one of the risk factors for suicide, and I think in some parts of medicine and some specialties, there can still be a difficulty, I think, for female physicians to feel like they belong in that profession. Maybe where they're underrepresented or they don't have, mentors who are guiding them. Mm-hmm. They don't have folks kind of telling them this is a place for female physicians to practice. They feel like they kind of have to prove themselves or that they're already at a disadvantage because of their gender. That can definitely be a contributing factor. Mm-hmm. I think often women in our society, if have a family or juggling multiple demands, women can kind of be in the sandwich generation, right, of taking care of children and also taking care of aging parents. Mm-hmm. And the demands that exist outside of work, I think, can also add up, leading to...
They're pulled in multiple directions.
Yeah, they're just juggling a lot. And so that can be a contributing factor for many physicians that are female. There is some interesting research, especially in kind of the primary care world, that looks at the amount of time that female physicians spend with each patient, and that's including, when they have an encounter or having an appointment, but also the amount of time that they spend outside of work charting and documenting. Mm-hmm. That there's kind of a thoroughness sometimes that female physicians, a dedication that they have to their patients, that can sometimes lead to, a limited work-life balance. Mm-hmm. They just, again, have a lot of demands outside of work, but also have high expectations for themselves in terms of their performance at work.
Got it. Well, they say that medical students, the rate of depression is 15 to 30% higher than the general population, with female students having a higher rate of depression, as opposed to females in other doctoral areas. I guess the same reasons apply to that. Are the students' percentage more than the already established physician out there,
So what we know from the research is that both medical school and the beginning of residency are high-risk times mm-hmm. for the occurrence of mental health concerns and also for suicide, for death by suicide. And there's a lot of different factors at play. We talked a little bit about relocation, right? If people are moving to train, to do their residency program, to even just start a new job, that can kind of disrupt their natural connections that they might have had, people that they would hang out with, their friends or families. All that social support can really be uprooted, which is a huge factor. I think both in the start of medical school and also in residency, there's a lot of kind of orientation around the culture of medicine, the culture of healthcare, and there are elements of that I think sets up an unrealistic expectation about what physicians are expected to be, right? And part of it is what society expects of physicians, like physicians are superhuman, perfect, mm-hmm. flawless, never make mistakes, put the needs of other people first, mm-hmm. right? Kind of put their own needs on the back burner. Right. And within many training and work environments, there can be some amount of mistreatment still that exists, right? Where medical students and residents can be berated for their mistakes or told that they can't slip up at all. And so there's kind of this development at times of this hidden curriculum that physicians have to be fully dedicated, give all of themselves, and that anyone that struggles isn't cut out for the profession. Right. I think those kinds of pressures and that culture can really, for medical students and for residents, foster that sense of I have to hide my humanity. I can't be my full self. I can't have my mental health concern. I can't show that I'm struggling. If I'm struggling, it's a sign of personal weakness. Mm. And oftentimes folks might hide their struggles until they feel like they're at a point where they don't know what to do. They don't know who to turn to for help.
We listened to Dr. Katie Godfrey, who's talking to us about suicide, but we're going to take a little break right now, and we'll come back in a short period.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasato.
We're back from our break speaking with Dr. Katie Godfrey on suicide prevention and awareness. This is Suicide Prevention and Awareness Month. And on the 17th of September is Doctors' Awareness and Suicide Prevention also. A contributing factor to how doctors can commit suicide is their easy access to drugs that can do it. That's an interesting point, I think, that makes us have higher percentages in the suicidal attempts. Now, how can people get help if they are finding themselves overburdened and the weight's too hard? Getting the information out about the bills that have passed to make it a little bit safer for them to ask for help seems to be a good thing. How do we get that information out there? Mm-hmm. I don't know if it's out to everyone. I didn't know about it till this interview. So how do we do that?
So we definitely can do more, I think, to promote the fact that these changes are happening within our licensing and credentialing systems. As soon as the year is up from Senate Joint Resolution 6 and we've officially can say that all of the questions have been removed from the licensure questions. We will certainly be on a campaign to promote, and maybe even we can talk about it. You can have me back on the podcast to talk about the fact that this has happened.
Okay.
But yeah, I
You're
think
always welcome. Go ahead.
There's a lot that we can do to make sure folks are aware of the resources that exist. And, importantly, if you or someone you know is struggling with your mental health or having thoughts of suicide, just knowing that you're not alone, and it's important not to kind of hold that burden on your own. It's really important to connect with someone you trust and to get help. For some people, that could be a peer support program that you might have within your healthcare organization. We have one at Christiana Care with a team specifically dedicated for physicians. So a physician can talk to another physician colleague about things they're struggling with, what's on their mind, and provide a connection to support resources. Many organizations also will have an employee assistance program which provides free and confidential counseling and therapy for anyone within the organization, and typically your family members as well. Mm-hmm. There are a couple of other resources that I think are worth highlighting here that listeners may want to know about. So there is a specific physician support line. It's called Physician Support Line. You can Google it. You can call. The number is 888-409-0141. And it's a free and confidential resource for all physicians and medical students where they can talk to a psychiatrist colleague. And it's open Monday through Friday from 8 a.m. to midnight Eastern Standard Time. Mm-hmm. And it's been a really great resource that has come about just since the pandemic, where psychiatrists are actually volunteering their time to provide that peer support and provide some recommendations about what someone might need. So, oftentimes when we're struggling, it can be hard to recognize or even to self-assess how bad are things right now, right? Because it's hard to kind of have that perspective on your own situation. And so it can be really helpful, I think, to talk to either a peer supporter at your organization, call the physician support line, talk to someone at your EAP to get that kind of perspective on, what do you recommend? What do you think I need? What's the best next step for me so that I can get support? The National Suicide Prevention Lifeline is available to everyone within the U.S. Mm-hmm. Recently, within the past couple of years, the number has changed to 988, so you can dial 988 or even text 988 from any phone, and you'll get connected with someone that can provide you with confidential and free support in a crisis, or even if you just want someone to talk to when you don't know where else to turn, and they can make some recommendations about how to support you.
You mentioned earlier that many of us know somebody in our profession that has done it. Well, I had a good friend that did.
So sorry.
And it was terrible. It was terrible for me, terrible for his family, and mine also, because we have been friends. We didn't see the problems that were happening in the face.
And I just want to say that that's common. It's very common, especially among physician colleagues.
I didn't realize. I thought I was pretty unique to it. It shows that web-based cognitive behavior programs can significantly reduce suicidal ideations in 50% of people. Should we train all doctors, or at least get some education out to all doctors to take a course in this to learn how to keep themselves safe?
I think there are a lot of different options that we can employ around, effective treatment strategies. Certainly, getting the word out that mental health among physicians is an important issue. It's an important thing to attend to make time for, to promote, and to reduce stigma around is huge. And I know more and more in medical school and in residency programs and beyond, there's just more dialogue and conversation about it. Mm-hmm. I think the biggest hurdle for most physicians is that initial recognition and getting into treatment or connecting to support. Mm-hmm. So the more that we can do to kind of reduce those barriers, the better. There's a lot of interesting models out there of ways to do that, including things like having medical students or medical residents kind of already signed up for an appointment with a counselor, and they just have to opt out of it. So they're already kind of opted in by default. They have to go in and take themselves out of the system if they don't want to have that meeting. There are also things like interactive screening protocols that have been implemented where, a program that you can access online anonymously to assess your mental health, to complete some questionnaires, and kind of see how you're holding up relative to maybe where you have been a year ago, or maybe to your colleagues and peers today. And they can make some confidential recommendations to you, or you can even chat with a counselor confidentially about your results and then your next steps. So those are some of the ways, creative ways that have been employed to help physicians, especially trainees, get connected with mental health resources. And we know that things like therapy, medication, and other kinds of treatments, once people are engaged with them, can be very helpful. It's just that initial barrier sometimes about getting them connected is the biggest hurdle.
Dr. Godfrey, this has been one very interesting conversation with you. I learned a lot, and I ask you out there that are listening, please, if you're having problems, we know how to get you help. All you got to do is ask. I'd like to thank you, Dr. Godfrey, for the information you've given us today. It's been very good. I hope that people can find this information helpful, and those of you that need help, there's help out there. Please feel free to look into it or call the numbers that Dr. Godfrey has spoken to. Until then, this is Dr. Nick Biasato signing off, and thank you for listening.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. Delaware Healthcare Reality is produced by Tom Mitten. I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.
If you or somebody you know is in distress or is struggling with their mental health, confidential help is available free of charge. The National Suicide and Crisis Lifeline is available 24/7 by texting or calling 988 from any phone. Physicians and medical students in the U.S. who want free confidential support from trusted colleagues can contact the Physician Support Line Monday through Friday from 8 a.m. until 12 midnight Eastern Standard Time at 1-888-409-0141. To learn more about National Physician Suicide Awareness Day and the campaign to prevent physician suicide, visit https://npsaday.org.